everyone, Deborah here. Welcome to our first webinar for the Canadian Heart Rhythm Society Allied Health Group for 2016. This evening's webinar will be audio taped and available on the web if speakers are in agreement, so it can be accessed for members at point of care in the future. The title of the presentation tonight is Left Atrial Appendage Closure for Stroke Prevention in Atrial Fibrillation, an Alternative to Lifelong Anticoagulation. The learning objectives have been circulated to you previously in an email. I want to thank Lynn Charbonneau. Lynn sits on our education committee for the Canadian Heart Rhythm Society and has been able to secure our presenters for this evening. It gives me great pleasure to introduce the presenters, and I have to admit my French is absolutely terrible, so I apologize in advance if I mispronounce your name. Our first speaker is Dr. Jean-Michel Paradis. He is a structural and interventional cardiologist at IUCPQ. He is an associated professor of medicine at Laval University. His work is dedicated to clinical practice and research, and he is actively involved in the LAAC program at his institution. Dr. Gilles E is an electrophysiologist at the IUCPQ and an associated professor of medicine at the Laval University. He has been involved in clinical practice since 1993. Also does research, and he specializes in the Atrial Fib and LAA Closure program. He is the active president of the Association of Cardiologists of Quebec. Very busy professionals for sure. We also have Mrs. Maryse Lemyre. She's a nurse clinician in electrophysiology at the same institution. She has a Bachelor of Nursing and a Superior Diploma in Management. She has a vast experience in the EP lab and works as a nurse clinician in the Atrial Fib and Genetic Clinic. She is also a manager of the LAAC program since its beginning, so another very, very busy professional. So on behalf of the Canadian Heart Rhythm Society Allied Health Group, we welcome you and thank you for taking the time from your busy schedules to share your knowledge and expertise with us. Thank you very much.
Thank you very much for this kind introduction. My name is Jean-Michel Paradis, and it's a pleasure to be here tonight to present on left atrial appendage closure. So I'm an interventional cardiologist working at Quebec Heart and Lung Institute, and I'm here tonight with my colleague Gilles E, who's an EP specialist, and Maryse Lemyre, who's a nurse practitioner in charge of the LAA Closure program here at Quebec Heart and Lung Institute. So I'll be presenting most of the slides tonight, but if you have any questions for my colleagues, please feel free to ask them on the chat portion of the webinar. So a few words on epidemiology of atrial fibrillation. As you know, atrial fibrillation is the most common form of cardiac arrhythmia. Approximately 2.2 million people in the United States are diagnosed with atrial fibrillation, and these numbers are projected to increase to about 3 million in 2020 and up to 6 million by 2050. And the prevalence of AFib is estimated at 1.5 to 2% worldwide, and the incidence of atrial fibrillation increases with age. Less than 0.1% of individuals who are less than 40 years of age suffer from atrial fibrillation every year, and the risk over the age of 80% is significantly higher in males compared to females of the same age group. And the average age of patients with atrial fibrillation is rising worldwide, around 75 to 85 years of age. What about the lifetime risk of having atrial fibrillation? The lifetime risk of atrial fibrillation is about 1 in 4 for individuals greater than 40 years of age. In comparison, the lifetime risk of breast cancer is about 1 in 8 at age 40, and the lifetime risk of hip fracture is around 1 in 6 at age 50. So it's a very common problem. As you know, atrial fibrillation increases the risk of ischemic stroke by about 5-fold in patients with atrial fibrillation compared to patients in sinus rhythm. And in fact, AF accounts for 36% of strokes in patients aged 80 to 89 years of age. And we know that strokes in atrial fibrillation patients tend to be more disabling and are more likely to recur or be fatal than strokes in patients without atrial fibrillation. In fact, the functional impact of atrial fibrillation-related strokes is shown here. About 31% of stroke related to atrial fibrillation are fatal. 28% are associated with severe neurological deficit, 11% are moderately disabling, and 17% are non-disabling. When you have a patient with atrial fibrillation, it's important to assess their thromboembolic risk, and to do that, you can use the CHAD score. The CHAD score has been validated by Cage and colleagues, and it's a system to establish the risk of stroke in patients with atrial fibrillations. And patients are awarded points based on their comorbidities. For example, 1 point for heart failure, 1 point for hypertension. Age greater than 75 years is also 1 point. Diabetes and previous stroke or TIA is 2 points. And the risk of stroke increases with the number of points that you have. To refine the clinical risk stratification for predicting stroke and thromboembolism in atrial fibrillation, Lip and colleagues validated the CHAD-VAS score. Interestingly, when you have a CHAD-VAS score of 0, your annual stroke rate is around 0.8%, so you still have a risk of stroke even if your CHAD-VAS score is 0. When your CHAD-VAS score is 1, your annual stroke risk is around 1%, and you can prescribe either oral anticoagulants or aspirin, and when your score is 2 or greater, then your annual stroke risk is between 2 to 15%, and oral anticoagulants are recommended. It's important to balance the benefit versus the bleeding risk of every patient, obviously. So, Coumadin and the newer antithrombotic agents like dabigatran, rivaroxaban, or apixaban are very effective in reducing the ischemic stroke risk in atrial fibrillation patients. However, these medications have significant limitations, for example, bleeding risk, drug failure, or even a compliance issue. So, as I just said, oral anticoagulation is standard of care for those patients, but it's not ideal for all. For example, with Coumadin and even with the novel oral anticoagulants, you have bleeding risk. You have to take your meds daily. Therefore, there's a high rate of non-adherence. These medications can complicate surgical procedures. For novel oral anticoagulants, there is no clear reversal agents, and the costs can be very high. When you have a patient with atrial fibrillation in whom you consider anticoagulation, it's important to assess the bleeding risk, and it should be part of the patient assessment before starting any anticoagulants. and it seems reasonable to use the Asblet score, which is on the right side of the screen. And a score of 3 or greater indicates a high risk, and it's important that you do a regular review of the patient to see if there is any complication after the initiation of your anticoagulation therapy. So despite increasing novel anticoagulants adoption, the overall rate of anticoagulation in high-risk non-valvular AFib patients has not improved. As you can see, only 55% of patients who should be on anticoagulation are indeed on an anticoagulation medication. So a lot of them are not taking any anticoagulation. So here, with this slide, what I want to do is briefly compare the risk of major bleeding when you compare the novel anticoagulants and the warfarin. So if you take rivaroxaban, for example, compared to warfarin, there was no difference in major bleeding. However, there was a lower rate of intracranial hemorrhage with rivaroxaban compared to warfarin. What about dabigatran now? The overall rate of intracranial hemorrhage was a lot lower than with Coumadin, and it was the same thing with apixaban. There was a lower rate of intracranial hemorrhage with apixaban compared to warfarin. And novel anticoagulants are associated with a 20% stroke risk reduction compared to warfarin. Either it's all the same. If you look at rivaroxaban, dabigatran, or apixaban. So let's talk a little bit about the left atrial appendage now. So we know that left atrial appendage is a major source of thrombi that cause stroke in atrial fibrillation patients. And in fact, 91% of all thrombi in patients with atrial fibrillation are found in the left atrial appendage. And the 4 largest TE studies comprising 1,200 patients showed that close to 98% of thrombi were found in the left atrial appendage. The anatomy of the left atrial appendage is very special. It's a multilobulated structure, and the most frequent number of lobes is 2. It's also a thin structure, and the mean atrial wall thickness is often less than 1 millimeter. You can use computed tomography to classify the anatomy of the left atrial appendage. So here on the upper left portion of the screen, you can see a typical cactus-shaped LAA. Here you can see a typical cauliflower or broccoli type LAA. There's in this panel you can see a chicken wing type, and here you can see a windsuck LAA. So the single lobe or windsuck LAA is an anatomy which one dominant lobe is of sufficient length. The chicken wing on the other side is an anatomy whose main feature is a sharp bend in the dominant lobe of the left atrial appendage anatomy at some distance from the perceived left atrial appendage ostium. Here you can see a cauliflower or broccoli type LAA anatomy whose main feature is an LAA that has limited overall length with more complex internal characteristics. Finally, a multilobulated anatomy whose main feature is an LAA with multiple protrusions. It's also important to understand the functional anatomy of the left atrial appendage. You can see, here you see the ostium, then you have the neck and the body, and it's also important to understand the plane of the left circumflex artery, which is right here. So what is the rationale for LAA closure? as I mentioned, thrombus arising in the left atrial appendage is the major cause of stroke in patients with atrial fibrillation, and percutaneous closure of the left atrial appendage rather than long-term anticoagulation could be an option to prevent stroke in atrial fibrillation patients. And recently, studies have shown that it's an effective procedure. And the goal of doing a LAA closure is to reduce the incidence of stroke due to the embolism from the LAA. However, LAA closure does not completely eliminate the risk of stroke, and obviously LAA closure cannot prevent other causes of stroke in patients with atrial fibrillation. Also, LAA closure addresses the unmet needs of stroke prevention in atrial fibrillation that persist despite recent advances in anticoagulation therapy. In fact, new oral anticoagulants reduce stroke risk, as you can see here, but have continued bleeding. In fact, the rate of major bleeding is still high, and there's still a high rate of discontinuation of the drug, between 21 to 25% over time. So, what are the devices that are available out there for LAA closure? You have two main types of devices: the endocardial devices and epicardial devices. So the endocardial LAA occlusion devices that are available are the following: the Watchman device, the Implanted cardiac plug, the Wavecrest, the LifeTech, the Occlutech, the Sideris patch, and the Cardia Ultrasept. And the most popular epicardial LAA occlusion device is obviously the LARIAT device. The Watchman LAA closure device made by Boston Scientific is made of a nitinol frame. It has 10 active fixation anchors, and it is covered by a membrane designed to block emboli and to promote healing. Worldwide, more than 7,500 implants have been performed, and more than 2,000 patients have been included in clinical trials. The device received CE mark approval in 2005, and it's approved in Canada since the beginning of 2016. The other device is the Implanted cardiac plug, the ACP, manufactured by St-Jude Medical. It's also a self-expanding nitinol device with two main components, one lobe and one disc. It has 8 different sizes between 16 to 30 millimeters, and the disc is 4 to 6 millimeters larger than the lobe, and it's a retrievable and fully repositionable device. The device received CE mark approval in 2008, and it's also approved by Health Canada since 2016. A few words on the Cardia Ultrasept, which is a new prosthesis. It's also a nitinol device covered with a membrane. It has distal anchors, and its main feature is an articulated joint, as you can see here. And around 40 patients have been done worldwide, and around close to 10 patients have been done here at Quebec Heart and Lung Institute. So finally, the LARIAT device. This device uses an epicardial approach, as I mentioned. It has a snare inside the epicardial space and a magnet inside the heart, and you close the left atrial appendage this way. So since the Watchman device is the one that we most commonly use here at Quebec Heart and Lung Institute, I just want to briefly talk about this device a little bit more. And during our heart team meetings, we review all the echo images and all the CT images of all our patients, and then we decide which device and we're going to use and which size we're going to use. So device sizing for the Watchman device is based on maximum LA diameter, and the maximum LA diameter, LA ostium size should be greater than 17 millimeters and less than 31 millimeters to accommodate all the available device sizes. The Watchman comes in a preloaded delivery system with, and there are 3 different axis sheet curves: a single curve, a double curve, and an interior curve. The device is 14 French. The outer diameter of the device is 14 French, so that's big. The procedure, what about the Watchman procedure itself? So the procedure is performed in a cardiac cath lab or in the EP suite. It does not necessarily need a hybrid OR. It's here at Quebec Heart and Lung Institute. Every procedure is done by a heart team composed of an interventional cardiologist and an EP specialist. Obviously, the echo specialist is involved. The anesthesia is there. Anesthesia is there for the general anesthesia, and there's also a clinical specialist involved. It mandates a transfemoral venous access under general anesthesia. It's a 1 to 2 hour procedure, and the hospital stay duration is 1 to 2 days. So when we do the procedure, we have to check different criteria before we release the device. We first have to check the position of the device itself, and the device should be at or just distal to the LA ostium. Then we check the stability of the device, and to test stability, we gently retract the deployment knob and let go. We do what we call a tuck test, and it's a pass or fail test, and if the device is well anchored, we can see it right away. Then we check the size. The device has to be compressed by 8 to 20% based on the maximum diameter at the shoulders measured on transesophageal echo. And finally, we check the seal to make sure that there's no significant leak around the device, and a residual flow around the device of less than 5 millimeters is acceptable. If all 4 device release criteria are met, then the device can be released. And to do that, we do 3 to 5 turns counterclockwise to release the device. So we expect that the device will get endothelialized by around 45 days based on canine models. And now I want to take the next few minutes to show you a quick video of the procedure. So I'm going to describe a Watchman procedure. So as I mentioned, the device is made of a nitinol, and it's covered by a PET membrane. Important to use PE during the procedure, so we get a venous access. Then we check the left atrial appendage anatomy. Here you can see the picture of the Watchman inside the left atrial appendage. Then we do the Trans-Septal puncture. We aim for a posterior and inferior stick. We get into the LA. We put a wire inside the left upper pulmonary vein. We bring the access sheet there. Then we exchange the stiff wire for a pigtail. here you can see the different types of LA morphologies: chicken wing, the windsock, and the cauliflower. Then we put the pigtail inside the left atrial appendage. We bring the access sheet there, position the access sheet deep enough to be able to deploy the Watchman device. We align appropriate marker band at or just distal to the LA ostium. We usually do areocaudal shot and an areocranial shot to see the ostium and to see the distal portion of the LAA. Then we bring the device, and then we retract the access sheet, and then the device is deployed right at the ostium of the left atrial appendage. We do a talk test, as you can see here. We test if there is any leak. We check on transesophageal echo to make sure that there's no leak, that the device is stable. Then we release the device. And as I mentioned, the device should get endothelialized by 45 days. So what about the peri-procedural care of those patients? The patients are usually admitted the day before the procedure. They return to the ward right after the procedure, and they are usually discharged on day one with a chest x-ray before discharge to confirm that the device is still in place. And because our patients have contraindication to oral anticoagulants, they leave with dual antiplatelet therapy for at least 45 days, and sometimes only one antiplatelet therapy. So I just wanted to show you this slide because you can see the medication guidelines that was used in the different studies using the Watchman device. So the patient was supposed to be on Coumadin and aspirin between the implant date and up to 45 days. At 45 days, the patient added transesophageal echo. If there was a complete seal, meaning that if there was no leak, then the patient, Coumadin was stopped, and the patient was placed on aspirin and clopidogrel up to 6 months, and then on aspirin 325 alone between 6 months and 5 years. However, if there was no seal on the transesophageal echo at 45 days, then the patient the Coumadin was continued, and aspirin was continued as well, and warfarin was stopped only when the seal was adequate, and then the patient was placed on aspirin 325 without any clopidogrel. So here's a slide showing all the studies that have been done with the Watchman device. So the PROTECT AF, which is the largest randomized controlled trial, the continued access program. The other randomized controlled trial is the PREVAIL trial, and there's also a second continued access program with the Watchman device. So overall, around 2,400 patients have been included in clinical trials, and more than close to 6,000 patient years of follow-up have been performed. So the PROTECT AF trial was a prospective randomized non-inferiority trial of LAA closure compared to Coumadin in non-valvular AFib patients for prevention of stroke. And interestingly, the one inclusion criteria was that the patient had to be eligible for long-term warfarin therapy. So across the trials, the mean CHAD score of the patients were between 2.2 to 2.7, and the CHAD VAS score was between 3.5 to 4.5. The implant success rate was between 91% to 95%, and the vast majority of patients were able to stop Coumadin at 1 year. The 4-year results of the PROTECT AF trial have been published in JAMA in 2014, and at 4-year follow-up there was superiority of the Watchman device over control when you looked at the combined primary efficacy endpoints, which included hemorrhagic stroke, cardiovascular mortality, and all-cause mortality. So what about the procedural safety profile? During the first half of the PROTECT AF trial, the 7-day safety events rate was 9.9%. However, there was a learning curve, as you can see here, and in the second half of the PROTECT AF trial, the 7-day rate of safety events was close to 4.8%, and in the other trials, this rate was around 4%. So clearly, there was a learning curve. Also, when you do a pool analysis of the PROTECT AF trial and the PREVAIL trial, which were the two randomized controlled trials with the Watchman device, there was less bleeding with the Watchman device at 6 months after the implantation, and there was a 71 relative reduction in major bleeding after cessation of antibiotics compared to Coumadin. So, as I mentioned, all the patients that were included in the PROTECT AF trial, in the PREVAIL trial, had to be eligible for oral anticoagulation. However, are there still patients who have contraindication for anticoagulations? And the answer is obviously yes. For example, even with the novel anticoagulants, a high proportion of patients are intolerant to the anticoagulation and consequently stop their medication at 2 years, as you can see here. Also, the rate of major bleeding increases when you combine aspirin or Plavix to novel anticoagulants. Here, with a combination of aspirin plus dabigatran or clopidogrel plus dabigatran. Finally, in elderly patients, the overall use of warfarin in eligible patients is only around 55%, meaning that 45% of eligible patients are not taking any Coumadin. So, based on this, Dr. Vivek Reddy and colleagues started the ASAP registries, and the purpose of this registry was to look at the safety and efficacy of the implantation of a Watchman device in patients with contraindications to oral anticoagulation without a warfarin transition. And it was a prospective non-randomized multi-center study. So to be included in this registry, the patients had to have a CHAD score greater than of 1 or greater, and they had to have a contraindication for Coumadin, either bleeding complication or hypersensitivity or something like that. So the mean age of the population included in the ASAP registry was 73 years of age, and the vast majority of patients were male. The mean CHAD score was 2.8. The indication for inclusion in the ASAP registry was mostly history of hemorrhages or a bleeding tendency. So the ischemic stroke rate of 1.5% was a lot less than the expected stroke rate of 7.3% based on the CHAD score of 2.8. So the conclusion of this trial was that LAA closure with the Watchman device can be safely performed without a warfarin transition and is a reasonable alternative to consider for patients at high risk for stroke but with contraindications to systemic oral anticoagulation. Now let's talk a little bit about cost effectiveness in a study published in Circulation in 2013. It was shown that LAA closure represents a novel therapy for stroke reduction that is cost effective compared with warfarin for patients at high risk who have atrial fibrillation. And another question is, does LAA closure improve quality of life? And the answer is yes. In this trial published in JACC in 2013, patients with non-valvular AFib at risk of stroke treated with LAA closure had favorable quality of life changes at 1 year compared to patients treated with Coumadin. We're going to skip the multi-center experience with the implanted cardiac time, the implanted cardiac plug for the sake of time, and I just want to quickly discuss the 2014 CCS Guidelines. So the Canadian guidelines mention that these non-approved LAA closure devices should not be used except in research protocols or in systematically documented use protocols in patients at high risk of stroke for whom antithrombotic therapy is precluded. And the European guidelines published in 2014 mentioned that interventional percutaneous LAA closure may be considered in patients with high stroke risk and contraindications for long-term oral anticoagulation, and it's only a Class 2B with a level of evidence is B. So my question is it time to change the CCS guidelines for LAA closure to be a little bit more inclusive? Based on the data that I presented, I think that the answer is yes, but I'll let you decide. So the final portion of my presentation will be on complications associated with LAA occlusion, because we have to be honest, it's an invasive procedure and it can be associated with complications. So what about the one significant complication that can occur is vascular complication. When we looked at the 7-day composite of procedure or device-related vascular complications, which included cardiac perforation, pericardial effusion with tamponade, ischemic stroke, and device embolization and other vascular complications, you can see that this rate was 8.7% in the PROTECT AF trial, 4.1% in the continued access program, and 4.4% in the PREVAIL trial. There was no procedure-related death reported in any of the trials. Of course, you can when you do this procedure, you do a transseptal puncture, so you can have a complication from the transseptal stick. However, transseptal puncture is very safe with experience and TE guidance, and I have to mention that persistent atrial septal defects after the procedure is a very rare complication. Of course, you can have a post-procedural effusion. However, the incidence is reduced with the elimination of the anticoagulation bridge. And to correct this complication, you can do pericardiocentesis and use anti-inflammatory drugs. What about the rate of cardiac perforation requiring surgical repair? It was 1.6% in the PROTECT AF trial and only 0.4% in the PREVAIL trial. And the rate of pericardial effusion with cardiac tamponade requiring pericardiocentesis or window was 2.4% in the PROTECT AF trial and 1.5% in the other randomized controlled trials using the Watchman device, the PREVAIL trial. Of course, LAA perforation can occur, but it is avoidable by the use of a 5 French pigtail, and it's also avoidable with the slow, gentle manipulation of the access sheet and the delivery system. Of course, if it happens, you have to reverse anticoagulation, and you can drain with autotransfusion. The rate of device-related stroke is around 0.4 to 1%, and the rate of device embolization is around 0.4 to 0.8%. The risk factors for device embolizations are the following: device undersizing, aggressive oversizing, if the device is off axis, if the device is too proximal, and if the patient converts from AFib to sinus rhythm. What about device thrombosis? It's a rare complication, around 0.3% every 100 patient years of follow-up in the PROTECT AF trial, and you have to order oral anticoagulation for 1 to 2 months and then reassess to see if the thrombosis has disappeared. Finally, you can have acute or a late erosion, and there are case reports of strut protrusion through the LAA into the pulmonary artery with the Watchman and with the ACP as well. So finally, a few words on the role of the nurse within the left atrial appendage closure program. So the nurse has a lot of function. First of all, she's the one who will receive the reference. The nurse will obtain all the relevant documents. She will revise. She revises all the data before the appointment. She then schedule an appointment at the atrial fibrillation clinic, and for remote patients, she plans transesophageal echo and a concomitant appointment at the cardiology clinic. At the clinic, she assesses the patient's understanding of atrial fibrillation and all the common complications associated with this arrhythmia. She clarifies the importance of anticoagulation when required. She calculates the embolic risk, the CHAD score, the CHAD's VAS2 score, and the bleeding risk, the ASBLED score, and if needed, the nurse reviews the reason why anticoagulation is contraindicated. Then she sits down with the patient and she describes the left atrial appendage closure procedure, including all the risk of complications. Then she explained the importance of doing a TE before the procedure, and she informs that the final decision of LAA closure will be made by the entire heart team. Here's an example of the sheet that we give to all our patients before the procedure. It's in French, but it basically explains the procedure and all the risks of the procedure itself. Then there's also a sheet with all the information, including the phone number of the atrial fibrillation clinic, so the patient is able to reach the clinical nurse whenever there's a problem. Finally, the nurse is very important to plan the procedure, and she will schedule, as I mentioned, the TE, and she will verify whether pertinent data is reported, meaning if there is a clot in the left atrial appendage, she will schedule a computed tomography for more refined planning if the renal function is adequate, and ultimately she will organize all the heart team meetings to review and plan all the cases based on comprehensive data that we collected. Finally, during the follow-up, she will plan the transesophageal echo at 45 days after the procedure, and she will meet with the patient following TEE to document if there is any bleeding on aspirin or clopidogrel, or if there is any embolic event, and then she will review all the cases with the attending physician. At 6-month follow-up, there will be a visit. The nurse will assess if there is any bleeding or embolic event, and there's another follow-up visit at 1 year, which includes a transesophageal echo, and then this visit is there to determine if the device status and the presence of thrombus on the device. Then at 2 years, there is a phone contact made by the nurse to determine whether embolic event or any hospitalization have happened. So all patients have AF clinic contact information and can reach the clinical nurse if needed, if there is a clinical event or if there is an hospitalization. So here's a picture of our LAA Closure team at Quebec Heart and Lung Institute. It's a very large team, and the team includes echo specialists, EP doctors, interventional cardiologists, and 2 outstanding nurses, Maryse Lemyre and Lynn Charbonneau. So in conclusion, atrial fibrillation is a very common arrhythmia. Atrial fibrillation increases the risk of stroke. 91% of all thrombi in patients with atrial fibrillation are found in the left atrial appendage, and 50 to 70% of all patients with atrial fibrillation at risk for stroke are not treated with oral anticoagulants. LAA closure has been shown to be effective and safe to prevent embolic events in patients with atrial fibrillation. A heart team approach, I think, increases the chances of having a successful program. A good nurse coordinator facilitates scheduling of the exam and appointments, communication with the patients and their families, and a good follow-up. So thank you very much for your attention, and I'm happy to answer all your questions. Lindsay, are you there?
Yes.
So I have a few questions on the chat. Do you have a waiting list for this LAA closure procedure? There is yes, around 1 to 2 months of a waiting list. And I have another question. Is the surgical removal of the LA during cardiac surgery safe to prevent clot as the percutaneous closure? Actually, there's no data. It's a very good question, but there's no data showing a superiority of one technique over the other. What is the average cost of these devices? It's around $8,000 per device. Are you limited on number of implants per fiscal year? Yeah, we're limited to 35 per year here at Quebec Heart and Lung Institute. And what is the MRI compatibility of LAA closure device? From what we know, there's no problem doing it. At least for the Watchman, the device is MRI safe. another question is there age limitation to be considered for LA closure? I think that, I mean, there is no age limitation. We use clinical judgment, and all the cases are discussed during our heart team meetings. We did a 92-year-old lady a few months ago, so I don't think that there is any age limitation as long as the patient is not frail and doesn't have any significant comorbidities that will limit his life expectancy. Another question is, if a patient just does not want to take an oral anticoagulant, can the LA closure procedure be offered to him? Maybe in the U.S. it will be the case if the patient is ready to pay for the procedure, but in Canada, it's not an indication as of yet. So, are there any other questions? So I think that we're good. There's no more questions on the chat. So I thank you very much for your attention. It was a pleasure to be with you guys tonight. Thank you.